Good evening, everyone.
Good evening.
My apologies for the technical hiccups. My name is Stephen Ganyani. I'm going to be presenting on higher order multiple fetal pregnancies, in particular the triplet pregnancy. And we're looking at the fetal medicine approach with a case-based application. I'm going to make it worthwhile for you. I know you waited for half an hour for this presentation to kick off. My consultant is Dr. Claudia Sverenga. He's a fetal medicine expert in Zimbabwe. Next slide, please. So the big question is why this case matters. Why are we here? Why are we talking about high order multiple fetal pregnancies? Whilst it's a rare condition, less than 1% of pregnancies, the issue is there is high risk. It's a high risk pregnancy. And these are the pregnancies that are going to be sent and referred to us as obstetricians and gynecologists, say from the clinics, and we'll be expected to manage them. 90% of these pregnancies will deliver preterm, and there is also a 5 to 10 chance of a 5 to 10 multiples of 5 to 10 higher perinatal mortality against if we measure this against a synchrotron, and also extremes of obstetric physiology are expected in such a pregnancy, and it requires specialist care. This is why we are going to talk about this. Next slide, please. So this is the layout of my presentation. I'm going to give a case presentation, and after the case presentation, we will talk about a discussion. I'm going to present to you a patient, CS. I'm sorry, with these slides, we changed them slightly, but we have to work with what we have for now. So I'm presenting Miss CS, who is 28 years of age. She's in a second pregnancy with one child alive. She was seen she was seen at 24 weeks of gestation and 1 day. Currently, as of today, she is now 27 weeks, and her last normal menstrual period was on the 7th of November 2025, with an expected date of delivery of the 14th of August this year. Her weight was 86 kgs, and the height is 1.75 meters. The BMI was calculated to be 28, and she was referred from a local private clinic after an incidental diagnosis of a triplet pregnancy. Next slide, please. So this is a patient who was on contraception, and she intentionally stopped the contraception, intending to fall pregnant in October of 2025. She was religious on a contraception until that day, and she did not have any preconception visit with the doctors or nurses or midwives, and there was no counseling that was done. She was not on folate supplementation, and she missed a period in November of 2025. And after missing a period in November, she tested. She had the last normal menstrual period in November, and she missed a menses in December of 2025. And on the 26th of December, whilst everyone was enjoying their Boxing Day, she tested for pregnancy, and it was positive. And from the time of discovery that she was pregnant until February, that was from December to February December last year, she was having headaches, which she did not seek medical attention for, and she was not on any treatment. She was not on any Martinics. She did not think it was important to seek medical attention for this. Next slide, please. So this was a spontaneously conceived pregnancy. There was no use of assisted reproductive technology. She planned to register a pregnancy at 5 months of gestation, as is common in our part of the world. Most ladies will only register their pregnancies or book them for antenatal care beyond 4 months. since she had no challenges in her first pregnancy, she did not see anything problematic with this late presentation. There were no financial constraints hindering this registration of the pregnancy. And she reports that the symptoms of pregnancy were milder in this particular pregnancy as compared to her first pregnancy. So she did not see any reason to seek medical attention. Her husband, however, encouraged her to take an ultrasound scan, which he eventually did at a local private clinic on the 16th of April this year. And upon that ultrasound scan investigation, they discovered that she had a triplet pregnancy, and she did not consult with the doctors at the private clinic. However, they just referred her to a group of hospitals for further management. She presented the next day. However, she presented late, so she missed the midwife-led teaching sessions that are done in the morning, and she was seen at the clinic, and she did not complain of. She had no complaints really, no generalized body malaise, no fever, loss of appetite or loss of weight. She had occasional headache, which started in December last year. On the respiratory system, she had a cough at night, which had to be probed. She was not complaining about it, but after probing, she then admitted that she had a cough at night, and there was no shortness of breath. She did not have nausea, vomiting, or diarrhea. She admitted to frequency of urination without nocturia, with nocturia of 7 times every night without dysuria. There was no agency, and she felt that she was having a complete bladder emptying. She did not have any limb weaknesses. Next slide, please. So, obstetric history, in 2022, she fell pregnant, booked at Mavuku Clinic, which is a local city of health, city health clinic. They managed the pregnancy until she delivered a baby boy. However, she delivered this child at a perinatal group of hospitals. They referred her because she had failed to progress. When she got to the hospital, she progressed well, being managed under monitoring with the pathograph, and she had no complications. She stayed in hospital for 2 days, and she's in a current second pregnancy. Next slide, please. She had a menarche at the age of 14. She would have 5 days of bleeding in a 28-day regular cycle. The coitic was at the age of 21. She admits to having 2 partners sexually in life, and there was no cervical cancer screening, which she attributed to procrastination. She knew about the program, but she would always procrastinate. She has used progesterone-only pills for 7 months after the delivery of the first child, and predominantly she has used combined oral contraceptives. HIV test was negative as of October 2025, which is 6 months ago. Next slide, please. So she has no chronic illnesses, and she's not on any medication. Next slide. In her family, there is no history of multiple gestations, and she is a housewife. She's married to a police officer. They survive on an income of $250, which is not a lot of money in Zimbabwe. I don't know about elsewhere. And they are renting 1 room out of a 4-roomed house, and they for this rental they use $60 and an additional $10 for energy bills. So in summary, I have presented a 28-year-old in a second pregnancy at the gestational, we presented it at the gestational age of 24 weeks we presented at the gestational age of 24 weeks for antenatal care with an incidental diagnosis of a triplet pregnancy, which was spontaneously conceived. Next slide, please. We examined the patient. She was alert. Her blood pressure was 132/83 millimeters of mercury with a pulse of 102 beats per minute. She did not have any jaundice. She was not pale. She was not cyanosed, no clubbing. There was no edema, and also she did not have any lymphadenopathy. The abdomen was soft, it was not tender, it was grossly distended with a height of fundus of 28 weeks, which was large for death. And also she was on palpation, she had 3 fetal pores that could be perceived. And with using a fetoscope, we could pick 2 fetal hearts. She had strial, a linear nigra, and no surgical scars were seen on the abdomen. The abdomen was moving well with the respirations. Next slide, please. Next slide, please. Okay. So we took some tests from here. Urinalysis was negative. I'm sorry for the spelling error there. These are old slides. The new ones, unfortunately, could not be flighted. I had corrected these things. Hemoglobin was found to be 12. The rest of the parameters were normal on the full blood count. She had a glucometer of 5.3. Unfortunately, in oral glucose tolerance test could not be done. HbA1c was done and it was 6.4%. HIV and RP-RT-PHA were both negative. Hepatitis B was also negative. Use and ease and liver function tests were normal. Next slide, please. So she had an ultrasound scan done at our fetal medicine unit, and they found to be in a second trimester with a trichorionic diamniotic pregnancy. Triplet A was in breech presentation. It was a girl. There was no it was on the maternal right. The estimated fetal weight for the triplet A was 644 grams, and the deepest vertical pool in fluid was 41 millimeters. Triplet 2 was also in breech, being a girl on the maternal left. Estimated fetal weight was 601 grams, and the deepest vertical pool was 42 millimeters. The triplet C was in low transverse with the head on the maternal right. It was a boy, and the estimated fetal weight was found to be 733 grams, and with a deepest vertical pool of pocket of 42 millimeters. There were no obvious structural defects or markers of chromosomal abnormalities noted on all 3 triplets. Fetal Dopplers and amniotic fluid were normal, as was pointed out previously. And we found that the pregnancy had a selective fetal growth restriction between triplet C. I'm sorry about the typographical error there. Between there was selective fetal growth restriction between triplet C and B with a discrepancy of 18%, and between C and A of 12%. And also the cervix was 34 millimeters. It was closed. There was no funneling, and the genetic syndromes could not be excluded by ultrasound scan, and to this end the patient was cancelled. It was recommended that this patient should take growth scans at 28, 32, and 36 weeks of gestation. These are just pictures to show off that the scans were done. I don't mean to go through them one by one in the interest of time. Next slide, please. We're going to skip quite a number of slides now. So you can see the lambda sign, there's fetal heads in 3 different colors. Next slide, please. These are just to show off. You can move on to the next slide, please. You can skip until you get to the summary. Okay, so I have presented a 28-year-old in a second pregnancy with a spontaneously conceived chorionic diamnotic triplet pregnancy, presenting late at 24 weeks of gestation with early selective fetal growth restriction and suboptimal antenatal optimization scheduled, and she's scheduled for growth scans at 28, 32, and 36 weeks of gestation. Next slide, please. Okay, at this point, I will hand over to the chairperson before we go into the discussion. Thank you. Maria, over to you. You are muted, ma'am. You are muted.
So thank you, Dr. Stephen, for the nice case series. I think you are done with the case series presentation.
Yes, ma'am.
Are you going on with another presentation, or we go to the expert opinion?
Okay, so I would want to discuss. I don't know, we have lost time. Do I still have time?
Oh, I think we can put the question and answers and discussion at the end of the whole presentation and after the expert opinion.
Wonderful. Allow me to proceed then.
Yes.
May I have the next slide, please? So, higher order multiple pregnancies are pregnancies that are consisting of greater than or equal to 3 fetuses simultaneously. The incidence has been on the increase, and this is attributable to assisted reproductive technology, and also the fact that ladies are generally becoming pregnant at older ages, as you can imagine. And this is rare, but extreme. There is a extremely high risk obstetric condition. It's considered a complication rather than a success of assisted reproductive technology. The rate of high order multiple pregnancies increased more than 400% since the 1980s to 90s. It peaked at around 193 births per 100,000. And there was a modest decrease to about 153 in 2009, by 2009. And remember, the attributable causes older maternal age and also assisted reproductive technology. However, it's important to take note that there is a 5-fold increase in the risk of stillbirth in such pregnancies, and also a 7-fold increase in the risk of neonatal death. So these pregnancies require specialized care, and this is because they have extreme prematurity. They have fetal growth restriction, as was seen in our patient with selective fetal growth restriction. They have an increased risk of structural anomalies, and also fetal demise is a high risk there. Next slide, please. So this type of pregnancy, high order multiple pregnancies, require multidisciplinary team approach, and you need a specialist for fetal surveillance, and it is mandatory. There is need for mandatory involvement of the maternal fetal medicine department. Next slide, please. So the key principles in the care of higher order multiple pregnancies is we need to diagnose them early and also risk stratify them at that particular point. And there is need for accurate determination of chorionicity and amnionicity, in particular the chorionicity, and I will explain. So there is the need for individualized care plan and also intensive fetal surveillance, which depends on the type of chorionicity that you have. And of late, they've also started talking more about the amnionicity in a recent paper. Prevention of prematurity becomes topical because we say that this is quite common, and also this is the biggest risk factor with the higher order multiple pregnancies. And also planning delivery in tertiary centers is important. You cannot deliver this patient at a lower level. The ultrasound scan done at 11 weeks and 2 days of gestation to 14 weeks and 1 day of gestation, which is the first trimester ultrasound scan. We look at an early ultrasound scan, which should be done at a time when the crown lump length is estimated to be 45 millimeters to 84 millimeters, and this corresponds to this gestational period that I've just alluded to. We need at this particular point on the ultrasound scan to determine the number of fetuses. Are they viable, and also the gestational age. We use the would you go back to the previous slide, please? We use the largest fetus to estimate the gestational age. And remember, there is a possibility of early fetal growth pathology, so we would prefer to use the largest fetus. And after determining the gestational age, we will not revise this in future. And the chorionicity, for determination of chorionicity, we may use the lambda sign, the T sign, and also for amnionicity, we're counting the number of amniotic membranes present and also their thicknesses. It's important. And to assign, we need to, at this particular ultrasound scan, assign the fetal nomenclature, whether the fetus is on the right or on the left, upper or lower. This is important for consistency, so that we don't measure, for example, the estimated fetal weight of one triplet and then assign it to the next triplet. For us to be able to draw the curves, we need to have consistency, and also knuckle translucency should be measured for all the fetuses individually. Next slide, please. So chorionicity is the single most important determinant of the outcome. It must be determined before 14 weeks, as I've already alluded to, or sometimes at the earliest opportunity, like in the case of our patient at 24 weeks, they then came for registration at Perinatal Group of Hospitals. So that was the earliest opportunity that we could then determine the chorionicity. And also chorionicity is important because it defines the surveillance intervals. It gives us the risk of, for example, twin-to-twin transfusion syndrome, twin arterial polycythemia sequence, and also it assists us in determining the timing of delivery. We have already established that they are going to be preterm, most likely in more than 75% of cases they will deliver preterm, but we then need to time the delivery. Next slide, please. Okay, so the first trimester, at that point, you need to counsel the patient. They may not know that they have a triplet pregnancy. They become anxious. They become worried about what it means to them. So we need to counsel our patient, and we need to talk about the miscarriage risk, which is higher than singleton, and also preterm birth, which is greater than 90% in triplets. And also the maternal complications. So we'll talk about these complications, and we need to counsel our patient on all this so that they are in the know. The counseling should be non-directive. And also they have an option to choose between continuation versus multifetal pregnancy reduction. And if they choose reduction, it also comes with a risk which should be talked about within the counseling. And there is a risk of extreme prematurity which should be talked about, and neonatal morbidity and mortality that is associated with the high order multiple pregnancies should be addressed within the counseling sessions. And you should also do these counseling sessions within ethical considerations. So the ethical framework is important. Remember the patient's autonomy, non-malefficiency, and also the option to do fetal reduction. And also, like I mentioned, the challenges that comes with the procedure. So this, the first image on your left is an internet. Sorry, this is a Williams 26th edition picture, which shows the lambda sign. So this was a twin pregnancy showing dichorionic, diamniotic, and you can appreciate the lambda sign. The middle peak image shows, tries to simplify what we are seeing in the first image. And the third image, which is appearing on your right, shows the images that were the actual images of this particular patient. And you can see that there is especially the top one, you can see clearly that there is the lambda sign. The bottom one was also a lambda sign because they measured the thickness of the membrane. It was greater than 2 millimeters. And I've also appended a picture of what the placentas will appear like when delivery happens. Next slide, please. This would be a monochorionic, so single shared placenta, a monochorionic diamniotic. These are textbook images that I have appended there together with an internet picture to just show what happens when you have a monochorionic twin or a part of a triplet where there is monochorionic sharing. Next slide, please. So the antenatal visit schedule should be coordinated because a multidisciplinary team approach, which consists of a core team, and the core team will constitute of an obstetrician and gynecologist, specialists, midwives, and also sonographers. And in addition to this core team, you can also have mental health professionals, physiotherapists, dietitians, and also infant feeding specialists coming in to assist. So you need to coordinate the specialist, the visits, so that when the patient comes, they will have their ultrasound scan done. They also have a chance to talk to the other different specialties. And the frequency of these visits it's more frequent than in singleton, every 2 to 3 weeks in the early pregnancy. And as the pregnancy advances into the third trimester, we then have a weekly or even a bi-weekly visit to these teams that I have alluded to. And we need to have more intensive, you notice that this is more intensive than twins because of the rapidity of which complications progress in high order multiple pregnancies. Next slide, please. So it's generally just to show that the number of antenatal visits is more frequent for those whom we anticipate more challenges. In a dichorionic diamniotic, you can have 8 antenatal clinic visits, but whenever you have a monochorionic where there is a shared placenta, the number of visits will then increase. And whenever there is a shared amnion, also you need to individualize the care in a tertiary fetal medicine unit. Like in our patient who has a trichorionic diamniotic, so for a triplet to have a diamniotic, it's says that there is a pair of twins that are in the same amnion, and that comes with its own risk. Screening and investigations on the maternal side, we are looking at full blood count. We anticipate that these people, mothers with higher order multiple pregnancies, we have a higher propensity to develop anemia, physiological anemia, and in our patient in particular, the hemoglobin was at 12 grams per deciliter, which was normal. And the blood pressures, they've got a higher propensity of developing gestational hypertension and preeclampsia. If you remember one of the theories of gestational hypertension, where they've a higher placental mass, which comes with more exposure of the semi-allograft paternal tissue. A glucometer is important, and also we should do it early and to be ready to repeat it as well. First glucometer was found to be 5.3. This is at 24 weeks of gestation. We intend to repeat this test. Emotional support is important at every visit. And also we need to look at the risk, the symptoms, and also signs of preterm labor. The patient must be fully appraised of these, the risk and the symptoms, and also the signs, so that they are also assisting us with monitoring. Next slide, please. On the fetal side, we look at aneuploidy screening. Remember, there is an increased risk for aneuploidy, and the knockout translucence becomes important. We can also use the cell-free DNA test, but with the one caveat there to remember that there are 3 fetuses in this particular pregnancy. If they are more like a quadruplet pregnancy, then you have 4 fetuses, and the DNA that you are testing within the maternal serum is coming from all of them, and you will then use the knockout translucency and other soft markers to assist us to identify, in particular, if we have say an aneuploidy, you then have other markers assisting in identifying which fetus may be affected. And we need a detailed anomaly scan to be done between 18 to 22 weeks, which we did not have the luxury to do because the patient only presented at 24 weeks. However, we did a detailed anomaly scan at that particular gestation. The ultrasound scan surveillance is essential, and every 2 to 3 weeks from the gestation of 16 weeks onwards, it should be done. We are assessing fetal growth, and we need to remember we have done the nomenclature, and we have assigned the fetuses exactly where they are, so that we are not mixing up. And now we continue to monitor their fetal growth, and we also look at discordance, as is the case in our patient with selective fetal growth restriction. And the amniotic fluid levels also are important to measure. Next slide, please. Together with the other tests that I've mentioned, it's also important to do Doppler studies, and within those Doppler studies, for fetal growth restriction, we look at the umbilical artery Dopplers. They're important, and for conditions like the twin arterial, the twin anemia, polycythemia sequence, it's important to look at the middle cerebral artery peak systolic velocity to see the moment it increases, it shows you that the red blood cells within the middle cerebral artery of that particular fetus are moving rather too fast, which is a pointer towards anemia. And if you have monochorionic if there are monochorionic components, we also have to screen for complications such as twin-to-twin transfusion syndrome, twin anemia, polycythemia sequence, and also selective fetal growth restriction, as I have already alluded to. So a shared placenta comes with higher complications. I've appended the pictures to just show the chorionicity-based risk stratification. Trichorionic, which is the first image on your left, top left, shows 3 separate placental masses, and this carries the lowest risk in a triplet pregnancy. And when they are sharing, two are sharing the same. So a dichorionic is when you have two placental masses. If you have a triplet and you have a dichorionic, it means two of the fetuses are sharing the same placental mass, and that comes with complications which I have already alluded to, including aberrant vascular connections. And the monochorionic, where all 3 fetuses are sharing the same placenta, comes with the highest risk. For example, the vascular anastomosis, and that comes with a risk. These are images that I borrowed from Williams' 26th edition. And on your left side, you see an arrow. You see an arrow in the image showing an aberrant vascular anastomosis, which allowed the yellow dye to move from the left side of the placental mass into the right side. And that same image is enlarged for better view. Next slide, please. In terms of prevention of preterm birth, remember we said this is the most dangerous outcome associated with high order multiple pregnancies. The evidence, there are evidence-based interventions. Cervical length surveillance is important. Vaginal progesterone is some limited evidence in multiples. However, it is part of the guidelines, so we can use vaginal progesterone. However, take note that the injectable progesterone is not recommended in guidelines, and secondly, is not recommended for routine use. Pessaries are also controversial, not recommended within guidelines, and no intervention is reliable to prevent preterm birth in higher order multiple pregnancies. That's the take-home message there. In terms of maternal complications, it's a mouthful, I tell you, but look at the images, how big this abdomen is. She must surely be going through a hard time with a grossly enlarged abdomen of that nature. However, the complications are not just limited to the weight and the diaphragmatic limitations. Hyperemesis gravidarum would then complicate the pregnancies earlier on. Anemia, gestational hypertension, and preeclampsia. And for this cause, it's important to then start your patients on aspirin from 12 weeks of gestation. We did not have this luxury in our patient because she only presented at 24 weeks, which is double this number actually of number of weeks. Gestational diabetes or hyperglycemia in pregnancy is an issue. Polyhydramnios, placental abruption, postpartum hemorrhage would then follow because of the increased distension and also that possibility of abruption, antepartum hemorrhage. Cesarean delivery is for higher multiple pregnancies is the delivery method of choice, and so that there is an increased risk there. Preterm delivery will happen in more than 75% in triplets. Some will say even 90% will deliver preterm, and 75% will deliver before 35 weeks. And selective fetal reduction could reduce the complications. However, it comes with its own problems, and there are physical challenges to it and also psychological impact. So she's going to be looking at this one child or these 2 children that would have been born out of a pregnancy that would have started off as a triplet, and you may suffer psychological trauma from that. Thromboembolic embolism is also increased in higher order multiple pregnancies, and regular monitoring is therefore essential. Fetal complications, I have appended a graph there to show the gestational age at birth against the fetal weight that is expected that is expected of these different types of pregnancies. And you will notice how significantly the birth weight reduces as the number of fetuses increases on that graph. Preterm labor and birth is the most important. It comes with morbidity and mortality. There is low birth weight, admission into neonatal ICU, intrauterine fetal growth restriction, twin-to-twin transfusion syndrome, and twin anemia polycythemia sequence, twin reversed arterial perfusion, which I will also depict in pictures just now, and congenital abnormalities, which we have alluded to. And there is also a risk of a miscarriage or a vanishing twin syndrome and cord entanglement in the monoamniotic gestations, and there is also an increased risk of stillbirth. Look at the differences on this picture in the fetal sizes. So fetal growth restriction is a reality, and the ultrasound scan is the gold standard. We don't want to use simplicity of under our height because it will not tell us that there is a selective fetal growth restriction. In the first trimester, we will not be able to predict this complication, and whenever the estimated fetal weight is less than 10% in one fetus, we define it. We define a selective fetal growth restriction. And when the discordance is greater than or equal to 20%, we then say it's time to refer to fetal medicine, as this is a patient who is carrying a selective fetal growth restricted fetuses. In our patient, it was 18%, which is borderline. Next slide, please. Congenital anomalies. I'm going to talk about congenital anomalies. So we know the three most common, the trisomy 13, 18, and 21. I will not go into the particular features of each. However, there is increase in these congenital anomalies, and also the testing it becomes more rigorous because we are now carrying higher order fetuses. You have DNA coming from all of them, so we use yes, we may use non-invasive procedures, but there is also an increased risk of invasive testing after they've passed the threshold. Next slide, please. Twin-to-twin transfusion syndrome is when there is a large connections. So these are large vessel connections between the fetuses, and one becomes a donor whilst the other becomes a recipient of not only blood but also total volume. So the one who have deficiency of amniotic fluid, whilst the other has excess. There is polyhydramnios and oligohydramnios for that reason. And in terms of management of this complication, it's staggered. If it's stage 1 of the quintuple staging, there is a chance that you can do amnio drainage, you can do septostomy, and try and manage this pregnancy. However, the challenge is it comes with amnionicity change. So the moment you do septostomy, they become a mono amniotic pregnancy. And when there are any stage between 2 and 4 on the quintuple staging, you then give them the option for fetoscopic laser photocoagulation at the equator, which comes with these one problems. For example, the post-laser twin anemia polycythemia sequence. The next slide just shows the quintuple staging. So in stage 1, we have the monochorionic diamniotic gestation with the oligohydramnios and polyhydramnios defined at 2 centimeters and 8 centimeters respectively. So there's just that difference in the fluid volumes. That's what happens in the first stage. In the second stage, look at the blood. There is absence of urine in one of the fetuses, who is the donor, whilst the other is more urine. And in stage 3, the abnormal Dopplers then emerge. And these abnormal Dopplers, we are looking at the umbilical artery Doppler, which is either absent or reversed, diastolic, reversed diastolic flow. And also we're looking at the ductus venosus, which becomes absent or reversed again in the diastolic phase. So the Quintero stage staging becomes important once you have such. The next slide shows the twin reversed arterial perfusion, where there is one cardiac twin together with a normal fetus. So the normal fetus heart will then pump for the two, both the normal and the cardiac pair. Next slide, please. Okay, so there is a missing slide in this particular slides that you are looking at, but I went on to discuss on twin anemia polycythemia sequence, where there is an imbalance in vascular connections, which is a slow blood transfusion. So you have cells being donated from transfused from one fetus to the other through small vessels, which are less than 1 millimeter in size, resulting in anemia in the donor and polycythemia in the recipient. And there is normal amniotic fluid volumes within the two. The picture that was showing on your screen was just showing a placental mass with the two cords that are intertwined, showing an entanglement of the cords, which is a complication that is common with, that is not common, yes, but it happens with the monochorionic monoamniotic pregnancy. The next slide that is showing now shows a fetus papyrus, where one of the twins within the same sac is squashed up. It then becomes calcified in that manner. Next slide, please. The next slide just shows different types of conjoined twins, which may result in these high order multiple pregnancies. The next one shows what is called the fetus in fetal, which is again a complication where one of the fetus becomes embedded into the body of the normal fetus. Would you show the next slide, please? Yes, so this is the fetus in fetal, now showing on your screen. There is another complication which is not on your slides, where there is coexisting complete hydatid form more with a normal pregnancy. It's very rare, one in about 20,000 to 100,000 pregnancies, but it comes with its own risk factors. For example, we know that there is increased placental tissue, which comes with preeclampsia, antepartum hemorrhage, postpartum hemorrhage is a complication, gestational hypertension is also there, and also preterm risk, or the risk of preterm delivery. However, with such pregnancies, there's only about a 40% or so chance of live birth. It is important to look at the nutritional and medical management of such pregnancies. So there is an increased caloric intake, in caloric need, there is increase in iron and folate supplementation, and also the need for aspirin, which I've already talked about it, starting from the 12th week after 12 weeks of gestation. And thromboprophylaxis becomes very important because of the increased risk. Next slide, please. So advanced fetal medicine interventions include selective fetal reduction, laser therapy, for example, in twin-to-twin transfusion syndromes, and also selective fetal therapy for anomalies, which requires a tertiary fetal therapy. Next slide, please. In the third trimester of such high order multiple pregnancies, weekly reviews become important, and growth scans every 2 to 3 weeks. Continuous CTG, continuous to CTG has got a limited role in prevention of in the preterm because of the maturity of the autonomic nervous system. Steroids are important for fetal lung maturation. This can be done whilst we are anticipating an elective delivery. Magnesium sulfate also for neuroprotection is important for gestations less than 32 weeks of gestation. Next slide, please. The timing of delivery basically should be individualized based on chorionicity, which I've mentioned already, and if we have complications. So typically for a triplet, we are looking at between 32 and 34 weeks, we should be delivering this patient. However, in our particular patient, because 2 of the fetuses are sharing the amnion, we have to individualize it according to her particular situation. We have to continue to monitor her for complications. Next slide, please. The next slide just shows the planned birth, which I have alluded to. I will not go into much detail. So with a triplet where there is amnion sharing, we need to individualize. Next slide, please. So the mode of delivery is usually bilateral cesarean section, and the vaginal delivery is really considered. We need to have a tertiary unit with a neonatal ICU in place. And next slide, please. So the place of delivery, we have already talked about it, tertiary center, and we have already talked about the multidisciplinary team. We are practicing in low resource setting, and there are challenges with the limitation of fetal medicine access. For example, in Zimbabwe, if it was not for Dr. Erenga, we would not have fetal medicine units. And also the availability of neonatal ICU is an issue. And you notice that our patient also only presented at 24 weeks of gestation, which is quite common in low resource settings. We need to turn this pyramid of care, as Dr. Erenga always says, and we need to strengthen our ultrasound scan capacity, and also have protocols in place for this management, so that there is unification of care. So in conclusion, higher order multiple pregnancies are ultra high risk conditions. They require specialist fetal medicine care. Intensive surveillance is important. Early intervention is key. And also the goal is to optimize fetal survival and to minimize prematurity related morbidity. Thank you. I've appended the references that I used.
Okay, thank you, Dr. Stephen, for a very nice and elaborative presentations. And because of our time, I would like to welcome Dr. Claudius Verenga for an expert opinion. Dr. Verenga, he is a fetal medicine specialist who is working at Zimbabwe. Welcome, Dr. Verenga, for the expert opinion.
Thank you so much, Maria. I think there's very little for me to say now. I think Dr. Gajane said most of the information we may want to know. Can you hear me, Maria?
Yes, I can hear you.
Yes, so I was saying Dr. Gajane said most of the information that probably people would want to know. But maybe to just emphasize and say, indeed, triplet pregnancies are complicated to manage. Our own experience in Zimbabwe for the past 7 years, we've been running fetal medicine units, is that most of our patients book late. Hence, they miss on the early management options that are available for this group of women. Which management options are we talking about? In modern practice, it is always good practice to offer couples with triplet pregnancy the option of fetal reduction. For those who book early, we always offer them fetal reduction. But let me tell you that from our own experience, I think there was only one Caucasian couple who opted for fetal reduction. Most of the couples decline. Actually, they want to go on and carry the triplets. Our outcomes have been mixed. In the early days, I think we're not getting great outcomes, but over time, we've improved our outcomes. I know that probably the international guidelines do not mention the role of cervical stitch as important in the care of the triplet pregnancies in women with a long cervix. But we have noticed a great improvement in terms of the preterm birth. When we started putting cervical sacrilege in our triplet pregnant women, so that the majority of them, we make sure they get their sacrilege very early when they have triplet pregnancy. And we've been doing great of late in terms of delivering them around 35 weeks, most of the triplets. There's the issue of probably discordant for fetal anomaly, which you also have to be aware of, that there is indeed an increased risk of discordant for fetal anomaly whenever we look after triplet pregnancies, which we have experienced in our country here. But generally, I think Dr. Ganyani has covered most of the issues. It is always going to be a challenge in countries where there is no fetal medicine expert to manage triplets, because scanning triplets on its own is a very challenging task that requires a high level of skill, especially identifying the complications that were mentioned here. So yeah, it's always a challenge, but it's always good to try and get the best scan you can in your environment to assess the pregnancy, because this is one of the pregnancies where traditional methods of assessing women and reassuring them doesn't work, like measuring their height or fundus. It doesn't work in multiple pregnancy. You need a proper detailed ultrasound assessment for you to figure out what is going on. Yeah, probably that's what I want to add. I'm available to ask any question that may arise, but I think Dr. Ganyani has been very comprehensive in his presentation. Thank you.
Okay, thank you, Dr. Varenga, for your expert opinion. And now I would like we are very late with time, maybe 10 minutes questions, Q&A. And I will start with in the chat box, Dr. Eskinda asked, can you please tell us how she was managed from the patient from case presentation? She presented at 24 weeks, but you just told us about the history, but how did you manage that patient? Did you give steroid or neuroprophylaxis? Also, how was the IGR managed with the patient? Is she still going on with the pregnancy? And what is so far are you following up with the patient?
Thank you for the question. So our patient is currently 27 weeks today. She is booked for a review at 28 weeks, where she will be scanned again for monitoring of the fetal growth.
Okay, I think Dr. Eskida have got the answer. Another question is, how was the diagnosis of IUGR established in this particular patient? I think Dr. Varanga, can you help us answer this question according to the ultrasound that you did to this particular patient?
Normally, to diagnose the the selective fetal growth restriction for twins or triplets, either we use the weight, the center, to say if the baby weighs less than 10%, that's a selective fetal growth restriction. But and also the discordance, the fetal estimate, which in this case probably was borderline, it was 18%. So those are our criteria we use to diagnose selective fetal growth restriction.
No, okay, so I have a question in that. If it's not borderline and you find like it's a severe IGR and it is 24 weeks, what is the proper management for that patient?
Currently, our management, because we are not yet doing laser coagulation of the placenta equator. So what we offer to those patients, depending on of course, on the chronicity, if it is a dichorionic relationship, we normally cancel the patient on the option of, actually they only have one option here, which is probably abandoning in utero in our environment. I'm saying abandoning in utero in our environment because of our neonatal unit capability. That our neonatal capability looks better after babies, looks better. Looks after babies who weigh 1,000 grams and above better than those who weigh less. So if babies are below 1,000 and the pregnancy is dichorionic, we normally give the patients the option of abandoning the other baby in utero and allowing the other one to grow. Because the option of taking out babies will mean the woman will lose both babies. If we are dealing with a monochorionic situation, in those cases, we counsel the parents that the demise of one twin may lead to vascular imbalance and hypotension on the survivor twin, which may cause brain injury. So the parents may choose either to continue the pregnancy, knowing the dangers that may be posed if the other baby demises. Again, the option of taking out babies who are below 1,000 grams is untenable because of the survival of these babies if it is in the public sector. But the private sector patients is slightly different because the survival of babies above 500 grams is much better. So in that case, the option of delivering both babies will still be a plausible option for the patient, for the parents of those babies. So that is the approach we take whenever we have selective fetal growth restriction in those kind of pre-viable periods. I hope I answered this satisfactorily there.
Yes, you did. Thank you. So another question, I think this is also for you, Dr. Following a positive cfDNA results, how can we determine which fetus is affected, especially in triplets or higher order multiple pregnancies? Like what additional investigation or diagnostic test can you perform to suspect this abnormality?
Yeah, so that is the limitation of the fetal cell-free DNA. To say when we apply fetal cell-free DNA tests to the twins, especially in the case of dichorionic twins, we might have to sample to go on and do an amniocentesis in both twins. But if there is already a defect or an abnormality on the baby, probably that could give an indication. But still, we have to sample both twins for amniocentesis. Then for monochorionic twins, because these babies are sharing the DNA, so the assumption is that if there's an abnormality, probably both babies are abnormal. So, but we still have to do an amniocentesis because let's remember, the fetal cell-free DNA test is a screening test. And while it is a screening test, we're not testing necessarily the baby's DNA here. We're testing the placenta DNA, of which there's a small risk of placenta-confined mosaicism or trisomies, which may sometimes make the interpretation of the DNA, fetal cell-free DNA, tricky. So in this case, we still need to do an amniocentesis. So in our case, we do amniocentesis, for the two sex in the case of diachoronic. In the case of mono, they will just take 1 second to send to the laboratory. And of course, the scan also helps in identify possibly abnormal babies if there are any features that may support the fetal self-readiness test result. That may help.
Thank you for the answer. I think the doctor was the question. I've heard the answer. And the third one was involving how do you manage, I think the doctor has already talked about how do you manage intrauterine fetal demise of one fetus in triplet or quadruplet pregnancy. You consider the patient and if she can proceed with the pregnancy. But maybe just one question, how long can she proceed with the pregnancy? Let's say like this patient with 24 weeks gestational age, and she has a fetal demise maybe of one twin. How long do you go until that you can say this is the limit, then I can deliver this patient, this live twin?
For intrauterine fetal demise of one twin depends. If the fetal demise happens very early, let's say in first trimester, in the case of triplets and one of them demises, this pregnancy will probably be as good as a twin pregnancy. So we will manage it like a twin pregnancy because that baby is going to involute with time. But in the case where the babies are grown, we still manage it as a triplet pregnancy and deliver it around 35 weeks, where the other baby is not going to dissolve. And management of intrauterine fetal demise of one twin also depends on chronicity. If the chronicity is trichoronic, normally demise of one twin, besides probably putting the woman at the risk of preterm delivery, doesn't do much to the pregnancy. The baby should be fine from that because there's no interconnection. The problem comes if the placenta is shed, then there's now the risk of hypotension, because remember these two babies who are sharing the placenta, they are balancing each other's blood pressure because of the intercommunicating vessels, right? So the demise of one twin will result in the fall in the balancing pressure on the demise baby. Hence, there's going to be hypotension and potential brain injury, which again, potential brain injury is very difficult to predict in these twins. Even if an MRI is to be done to try and look for it, it's difficult to predict. So we monitor the survivor twin by doing the MCA Dopplers, umbilical Dopplers, and if it is an early demise, we still treat them as they become like twins. If they were triplets, if it was twins, then they become like a singleton. If it was an early demise, but if the demise is late and the demise baby persists, we treat it like twins and we deliver at the time where the twins are supposed to be delivered. The same way as triplets, we deliver at the time when the triplets are supposed to be delivered. But we do not offer early delivery for demise of one twin because it has been shown that it's not preventive enough for the survival twin as far as brain injury is concerned, unless if there is evidence of fetal compromise on the survival twin. Then in that case, we take out the we take out the babies. If there's evidence, because we'll be checking Dopplers, mid-cerebral Doppler, umbilical Doppler, DV. As long as there's no evidence of fetal compromise, the pregnancy goes on until that scheduled time.
Okay, thank you for the very elaborative answer. Another question was particularly about the laser therapy, but you said you're not also doing in Zimbabwe. I've never seen it done also in Tanzania. And doctor, I think is from Ethiopia. I don't know if he said also it is not done. So I don't know. Maybe South Africa is the one which they're doing the laser therapy, and maybe other countries. So I think this question was particularly like if you are doing laser therapy, how do you do it?
Of course, the laser therapy is something that is done fetoscopically. using a fetoscopy. I think probably most of you have seen laparoscopy. It's kind of the same, but the light sources and the trocars are much smaller. So it's done the same way with a laser coagulation probe, which is used to coagulate the equator. The equator is where the two vessel, the vessel from the two placentas meet. So that whole area is coagulated. Coagulation is a way of destroying the communications, the arterial to arterial, venous and arterial venous communications that are between the two placentas. While we do not offer laser therapy yet, the way we manage conditions such as TTTs for now, we are doing amnio drainages. So for twin-to-twin transfusion, we do amnio drainage, where we do serial amnio drainage and we monitor them weekly for any reaccumulation of fluid. And so far, we are getting very positive results by doing amnio drainage, but we have very close plans to start laser ourselves. Yeah.
Okay, thank you. I think this other question goes for Dr. Stephen. We saw that the family is making $250 per month. So there are I think Nancy is asking like, so what is like in counseling of these patients? You know, she's expecting triplets and there is low socioeconomic status. So can you counsel them according like with socioeconomic status to give for fetal reduction? Or did this particular patient was counseled for fetal reduction?
Right. So what we do in our unit is we do not work alone. We actually work with a team of family support specialists and counselors. So for all the complicated pregnancies, they undergo a session with these guys to address their socioeconomic challenges and issues. And we also, through the social welfare office, for all women carrying triplets, we try to through the matron's office, our hospital matron's office, to mobilize the resources for the couple, because we are aware of the serious socioeconomic challenges carrying three babies will pose to the couple. So our counseling normally takes into account all those factors to say they should consider fetal reduction as an option because of the possible burden they will face, number one. Two, the complication that these pregnancies face, which is number two, and also the going home rate. The going home rate of triplets is not 100%, even in our setup. I mean, women taking all the three babies home is not 100% in most cases. Probably, I'll put it at 30% in our environment to say probably 30% of women who carry triplets from first trimester will be able to carry three babies home. Some will lose babies along the way, either after birth or through miscarriages and so forth. So, yeah, so we counsel parents holistically in the context of all this. Yeah. So we do not work in silo. We actually work with a team of support staff who attend our clinics, who talk to patients, who will understand the whole pregnancy care situation, because they will be in the consultation room with us, this team of specialists I've mentioned. Thank you.
Okay, thank you so much, Dr. Verenga, for your expert opinion. I think we have learned a lot today. I think most of the questions that have been asked in the chat box has been answered. So we thank you very much, Dr. Stephen Nganyani. He took us through the clinical case and also the presentation of multiples. And also Dr. Verenga came and explained to us about the management of high order pregnancies and how can we go about it. I think now it's a wake-up call to do like what Dr. Verenga did, for more of obstetrician and gynecologists to go for super specialty in fetal medicine. right? Because we need more of fetal medicine specialists. So this is a wake-up call for all of us to go and apply and advance far to go to fetal maternal specialists. So I would like also to thank everyone who participated in this webinar case series of today. So the next bi-monthly case series will be, we are going to our neighbors, we are going to Kenya. So Kenya, get prepared. We hope we'll be having a wonderful case series, and it will be on Saturday on 23rd of May at 17 hours. So we'll share with you the slide. The presentation will be uploaded at Watog Africa YouTube channel. I think there you can access the materials and read far, because the presentation, you can all agree, it was very good. Thank you for the presenters. Thank you everyone. And this marks the end of our bi-monthly meeting for today. So thank you so much.
Thank you so much, everybody. Amazing.
Thank you, Maria, for also anchoring the session. You didn't thank yourself, so thank you.
Thank you.
Thank you for the
Thank you.
and you look beautiful. Bye.
Thank you.
Thank you, guys. Bye-bye.
Bye-bye.
Great. Thank you, everybody.
See you after 2 weeks.